Thank you very much. Thank you to be there, and I maybe thank you to Jérôme to have given to us a very important example of the complexity of an hospital. Really, hospital is a word of complexity. It seems that we have all complexity of industry in the same site, and so our poor little brains are very small to understand all things in the same time. So we need help. I need up to 4 slides first, you see, so so for CEO of hospital, it's very difficult. And I'm a CEO of Groupe Hospitalier Paris Saint-Joseph. Groupe Hospitalier Paris Saint-Joseph is owned by Fondation Hôpital Saint-Joseph. That has been founded in year 1884, and we have now 2 hospitals: Hôpital Paris Saint-Joseph in the Paris 14 area, and Marianne Long in Plessis-Robinson in 92 department. Saint-Joseph is a very generalist hospital with emergencies, maternity, important cardiovascular, pole, and gastro and digestive, and so on and so on. Marianne Long is a very well-known specialized hospital on cardiothoracic and vascular for adults and children. So we have health centers, 5 health centers on Marie-Thérèse Association, and a nursing training institute. Some key figures you see: 85,000 hospital stays, 55,000 emergency visits, 3,400 births, and so on. And by example, we are quite 4,000, and we are the first private non-profit hospital in France. What would we do exactly? What is the idea of the hospital virtual twin? The idea is the future is supposed to be an hospital virtual twin because, as I said, all processes are so complex that we can't approach them in the same glance at each time. And so, you see, we have identified five main processes. And I will give you, after that, examples of each process. So, hospital care delivery, digital patient experience, after that, medical workforce, operating performance, and at the end, healing and wheeling. So, my examples. On hospital care delivery service, we have many things yet. These things have to be enhanced to be better. But by example, on zero paper, in Saint-Joseph, since 2014, we have zero paper on all medical files. Nowadays, since December last year, Marianne Long is in the same situation. So now we have, by example, to work with IA to recognize in textual indication, we have to recognize these indications to fill the data system. Why? Because if you want a very good exploitation of your data, you have to identify them, to precise them exactly, instead of what you are not able to have conclusion on this. We have to buy another robotic surgery of new generation. It's very difficult. I said this with one colleague here a few minutes ago. It's very difficult, and since 1998, when Da Vinci has created his robot, quite nothing has been invented since 30 years, you see. So we are waiting this, and robotic surgery, we think that has to be patient-centered, maybe linked with imaging, and maybe something very, very automatic be done by robots. On 3D printing, here we are in the field of what we do. We, by example, modelize prostheses, vascular prostheses, orthopedic prostheses, and stomatologic prostheses with 3D printing with data taken from imaging. For patients and for medical doctors, we have many mobile apps to simplify the life of or for professional or for patients. And then the patient 3D platform, we have begun that, and that has to enhance, it's the beginning of this, to give better information to patients. After that, for patient experience, you see we have written geolocalization. We have this. It's very simple for stretcher bearers nowadays to find all the devices that are not utilized. It's very simple for them to drive patients where they have to go. And after that, we are working on the patient experience, and by example, to drive them in imaging, functional exploration, and so on. So geolocalization will help us for this. We have many processes, many very complex processes. Ambulatory process, by example, we have here another geolocalization, and we exactly know for surgical ambulatory where is the patient at each time. When he goes out the operating room, when we have to call for the person who will take him to go out of the hospital, and so we have something very interesting on this. Now we are working on anticipation and on corrections, on the modification of process in case of something goes not well. And then patient process discovery, really, we try to modelize other pathways, like, by example, endoscopy or medical or other medical pathway. You know, when we speak of patient experience, I often dream to be an airport CEO. Why does that? Because if I would be this, I would exactly know where the patient goes. It's not our case. We don't know exactly what he has when he's coming to us. I would like exactly, he wouldn't change of itinerary when he is in the plane. You know that a patient can change of itinerary if you have a different result on the scanner or something, and so you have complementary exam and so that. He pays when he is a patient, flying patient. And, and when we are a CEO of an airport, all the people are well-being. So you see why I sometimes dream to be an airport CEO. This difficulty in hospital, we try with Dassault to treat this with our virtual twin, and you see why all these pathways are so difficult to draw. Workforce of future for medical and paramedics. COVID has been very, very hard for everybody, especially for people working in health. And we know that on human resource, We have to enhance our policy. We have to give respect. We have to give training more and more than we don't yet. Many publications say in 5 years, maybe 50% of people working here will be out of the hospital, and it's an international publication. You know how that's difficult for everybody in health to help human resources to develop. We have campus formation with two universities, with schools, central and polytechnics, and we try to give training for our staff, but for many doctors abroad that are learning vascular surgery, by example. And then for the virtual medical practice, we are with Dassault in 2 twins on the heart and lung virtual twins. And we have been to see a project of brain twin. So, one operational performance. I said there were many pathways. So these many pathways, we have some management tools, operating rooms, consultation, less for hospitalization, but nothing is linked one with the others. So the virtual twin has to do this. And you see what is the vision. From what we have, some paper documents, we see all the pathway here, and the collaboration within this, the artificial intelligence that could be in a virtual twin will help us at each time of the day to manage all our pathways and to be better for patients, because we are really patient-centered. We are patient and staff-centered. And here, see you in 2025. In 2025, we will open the future Marie-Lajonchère Hospital, quite near the actual, and Dassault has yet drawn the first envelope virtual twin. You see, he's turning under our eyes. We have a maquette in 100 scale maquette. It's really like this. Maybe I prefer this. And this hospital, Jérôme said something on the conception on air. We will do that, and we will try to have the new caregiver space, a new noise management. You know that hospitals are very noisy inside, and patients have problems with this noise. I said something on the air, and it's we have to design this with the hospital twin and customize patient rooms, because it's not really things in the well-being of patients. We have to do better. So here we are. I would like to thank all the team of Dassault, Bernard and Patrick especially, but I know now all the team, and this fusion of culture between hospital people and engineer is something fantastic, and I think that will have been a very, very good project. Very good. Thank you to you all. Thank you.